first speaker on stem cell uses in workers' compensation, Dr. Brad Goodman with Alabama Orthopedics, Spine and Sports Medicine. I am very pleased to introduce Dr. Goodman, who joined Ortho Alabama Spine and Sports in 1994 as one of the first interventional physical medicine doctors in the country. He is a leader in minimally invasive interventional therapies. These therapies treat a variety of conditions without the risks of surgery. He is a national instructor and lecturer for the Spinal Intervention Society, the North American Spine Society, and the American Academy of Physical Medicine and Rehabilitation. In 2008, he was awarded the PASOR, is that how you pronounce that? Distinguished Clinician Award for his contributions to teaching intervention to physicians from all over the country. He is an editor for the Atlas of Spinal Intervention, the leading book on minimally invasive techniques. He has published extensively on topics from kyphoplasty to spinal interventional guidelines. Dr. Goodman is the first physician in the country to offer Superion, a minimally invasive implant to treat spinal stenosis to help patients avoid major decompressive spine surgery and fusion. He is a principal investigator and key opinion leader in regenerative stem cell therapies. He received his undergraduate degree from Vanderbilt, where he was captain of the varsity tennis team and was a Scholar Athlete of the Year in 1986. He was also the Alabama Tennis Player of the Year in 2010. Very cool. Dr. Goodman received his medical degree and did his residency training at Emory University. I hope everybody at this point is feeling pretty inadequate. Without further ado, I welcome Dr. Goodman.
Thank you. I don't know who wrote that bio, but I want to hire that person. So thank you for allowing me to come here today to speak about regenerative therapies. The title said Regenerative Therapies in Workmen's Compensation, and really I just hope to give a basic overview so we can get a handle on regenerative therapies as it relates to orthopedics. Hopefully I'll have a lot of time left over for questions, because I think almost in the question-answer period, more of the real issues come out in terms of what people are most interested in. I want to thank Tim Davis, who is out in California, and another gentleman, Marco Baudour, who I have borrowed the majority of these slides from for this talk. And so we're going to talk about the truth, the myth, and future of biologic therapies. So wine, okay? The truth is it's an alcoholic drink made from grapes, okay? With a lot of marketing and promoting and selling of the product, the myth is that it's an alcoholic drink that makes you likable, attractive, and funny. Okay? The stem cell, the truth is the stem cell is a cell that's capable of becoming any type of cell in the body. So if you have a stem cell, theoretically you can grow it and it will become a liver or muscle or heart. And then with a lot of marketing, you can market these things and say, hey, I have a stem cell therapy and we can treat multiple sclerosis, Parkinson's disease, arthritis, lung disease, rheumatoid arthritis. There are a lot of what we call observational studies, which is evidence, but it's more anecdotal type evidence. It's not a strong evidence to try to support these claims. But the truth is that in today's day and age, it's still a hard to study science. Why is it so hard to study? Well, first of all, anytime you do an intervention to a patient, there's a very, very high false positive rate or placebo effect. So in order to get good quality evidence, you have to compare your treatment against a placebo. And the placebo itself works about 30% of the time. So you've got a really high bar to really show a strong effect. The other thing about regenerative therapies, if you think about what you're trying to do, you're trying to regrow a tissue. It takes a long time to work. It takes 9 months for an embryo to become a fetus, okay? It takes a long time to see a biologic effect. In the studies that we've done, for instance, when we do what I call degenerative injections, where we try to destroy tissue, you see an effect the next day. It takes a day to tear down a house. It takes a year to rebuild the house. So it's a very, very hard to study treatment, and it's very expensive to study. It takes millions of dollars. These are just some examples of some of the things that are either actively used or being actively studied. And we've had experience with most of these biologics. This is probably the most important slide when you think about regenerative therapies. I like to divide it up into stem cells, which are like seeds. If you were to plant a flower, you would plant some seeds. And you would plant the seeds in soil, which is like a scaffold to hold the root system, to hold the thing in place. And then you would put some water and some fertilizers in there to promote the growth of your seed. And it's the same thing in regenerative therapy. You need stem cells, you need scaffolds, and you need growth factors. Another one of the problems with studying regenerative therapies is when biologic companies go to study a product, they want one active ingredient. But the key may be to have multiple active ingredients for the product to work. These are some of our essential cells in our bloodstream. So this is a red blood cell, this is a white blood cell, and this is a platelet. And these things are streaming along in our body. And if there's an injury, like a cut, either inside our body or outside our body, we bleed. And we start bleeding these cells. And one of the things that happens is this platelet gets activated. It gets really, really sticky. So here's an example. This is not my patient, but this is an example of somebody who has a small tear in their Achilles tendon. And here's the tear. This is an ultrasound-guided intervention where platelet-rich plasma is injected into the tear. And then over time, you can see that this tear inside the Achilles tendon has healed. Well, what is it about platelets? Platelets actually they contain actin and myosin, which are the active units in muscle. I like to say platelets have the strength of 10 men, okay? They're like a muscle fiber putting things together. They act as a good scaffold. So this is the platelet holding force of a slow twitch muscle fiber. So not only do platelets hold things together and act as a scaffold, they also release granules or proteins that are like fertilizer that starts telling the tissues, the local tissues, to start to heal. Now let's move on to stem cells. Stem cells basically come in two varieties. There's autologous stem cells. Those are stem cells that we have, that we donate to ourselves. And then there's allogeneic stem cells where there's some donor and some pharmaceutical company has packaged these cells and put them in a vial and frozen those cells, and then we bring them back to life by thawing them out and injecting them. So they come in two varieties. The autologous stem cells are very appealing to lots of folks because it's our own tissues. We're donating our own cells to ourselves. And the way we donate our cells is through our bone. They live in our bone marrow, and our fat. So you can suck these cells out of our fat. And then these cells are spinned, and we isolate what are called the MSCs, the mesenchymal stem cells. Now, all this sounds very appealing, I know. Here's the problem, okay? The FDA says that your cells don't really belong to you, okay? In other words, I can take your cells and I can isolate them, but they will not allow me to expand them and grow them. I can do it, I can expand them and grow them, but I can't give them back to you, okay? So the amount of cells I get from you may be very minimal, but if I could expand and grow these cells, I could potentially give you a much bigger dose of your own body, okay? That's against the law. That's why a lot of people will go to the Cayman Islands, or they'll go to Germany, or they go offshore to have stem cell injections, because in those countries there's not rules against that, laws. So you get bone marrow, you take the cells, you expand them in culture, okay? The pharmaceutical companies have patents on this, and then these cells could be injected into heart, pancreas, bone, cartilage, knees, wherever, and the hope is that they become that tissue. Now this is basically a diagram of healing. So we have an injury, we bleed, we form a clot or a scaffold. There's some inflammation, which is basically telling the body that we need to continue to bring in various proteins and make collagen and make things that cause tissue repair, and then ultimately that tissue repairs and remodels. The problem is that we get stuck in the inflammation stage, and cellular proliferation and tissue repair don't occur. So we have a lot of experience with stem cell products in the back, in the spine. And this is a normal, healthy disc. And what that means is the disc is well hydrated, kind of like a plump grape, okay? But some of our discs start to dry out, and they lose their water content, which is why this disc is bright white and this disc is dark. These discs potentially are more likely to become a source of back injury and back pain. And so we direct some of our therapies, some of our regenerative therapies, to turn this disc back into that disc. I'm sure that a lot of you are aware of the disc is where most good therapies go to die. So there have been a lot of treatments over the years to treat back pain, a lot of interventions, and that's where a lot of them stop. They don't get very far. So the disc has been a very, very hard area to treat and to cure. If we look at the animal data of stem cell therapy, it's very encouraging. And so I put this one slide in there to say, you know, all these vendors that have stem cell products, they all have animal data to support their use. What they don't have is human data. There has been one study by Patine, who's in Colorado, and he did autologous stem cells, so he sucked bone marrow from his patients, and he injected it into degenerated discs. And he found that most of these patients did very well and had improved back pain and function. What's interesting to me, and this slide is hard to read, but if you're over 40 years old, you're less likely to have enough stem cells to have a meaningful result. So from an autologous stem cell point of view, if you're over 40, it's less likely to work because you don't have as many stem cells in your body than if you're 20. The problem is 20-year-olds really don't need the stem cell injections like the 50 and 60 and 70-year-olds. So again, it gets back to the ability to expand our tissues, or the pharmaceutical companies providing the tissue for us. There is a company in Australia that we work with called Mesoblast, and they've done both phase 1 and phase 2 studies with mesenchymal stem cells. These are now allogeneic. These are from donors. They've expanded these into a low dose and a high dose group. So we're talking about 6 million versus 18 million cells. And they have found promising results. We have been involved in their phase 3 study, but the results are not available yet. So hopefully, if those results are positive, they will be the first company to have an FDA-approved stem cell product that is on the market. Right now, there's nothing that's FDA approved. So the low dose group actually did better than the high dose group. So summary. So stem cells promote and repair, and they also decrease inflammation. A lot of what we see on the internet and on TV and radio is marketing. And unfortunately, there are few randomized controlled trials out there. They're very expensive, but ultimately, they will prove the science. I believe that regenerative therapies are going to change our treatment algorithm. Instead of injecting steroids, we're going to more and more be injecting regenerative therapies. And I do think that biologic therapies will be the standard of care in the next 5 to 10 years. One possibility is that you will go to your doctor, you will get your stem cells sucked out of you, and you will send those to the bank, and they will expand those cells for you. Just like you put money in the bank, you'll put your stem cells in the bank. And then 10 years later, you'll say, oh, my shoulder hurts. And you'll go to the bank and you'll say, let me have some of my cells, I want to put them in my shoulder. So instead of putting a steroid in your shoulder, you'll go to the bank and you'll do a withdrawal, and you'll put your own cells in your shoulder to help your tendinitis. That's the future that I see in the next 10 to 20 years. And that's it. So I hope I left time for questions, did I? Please. Probably because the pharmaceutical industry has a strong lobby, and they're more connected to the FDA, such that the pharmaceutical industry sees the potential of these cells, and so it becomes a political sort of football in terms of who owns these cells. So I think that's part of the problem. I do think that the FDA is also concerned about safety. With the more you manipulate these cells, the more likely they are to get infected. Just handle them. So I would worry about causing infection. So if you had a product that's been sterilized and it's had rigid control versus a nurse drawing blood or sucking bone marrow and then transferring it to this tube and that tube and expanding them in culture, it goes through many more hands. So I think there are some compelling reasons not to do it, but also I do think that it's a political issue.
What's the lifespan of bank cells?
I think as long as they're frozen, and I don't specifically know the answer to that, but I think as long as they're frozen, they should be fine indefinitely. Certainly, your cells could be taken out of the bank, some of them. They could be thawed, and they could look at them under a microscope and see whether or not when thawing they become alive and active. So there would be ways of testing for that.
Like we had our children's umbilical cord, that's what that procedure was, right? It was removal of stem cells.
That's right. We did that too. So we didn't do it with our first child, but we did it with our second child. So the umbilical blood is rich in stem cells. So you save those cells, they're putting them in the bank, and theoretically, if you get sick, you potentially have a matched donor right there. And theoretically, one day they could take those cells and maybe grow an organ that they could use to transplant. So I think that's a reasonable thing to do. I don't think the technology's there yet, or we'd hear about it, but that's exactly why you did it. So banking stem cells is already going on. I just think it's going to become more prominent.
So even if you're post 40 or 50 years old, you can still bank stem cells? Are they still effective?
I do think there's some banks in Florida that will work with you on banking your own cells. There's none in Alabama that I know of. I think that's a reasonable idea to take your cells, but you're not going to have a lot of them. But if you take those cells and grow them in a petri dish for 6 weeks, you now have a lot of cells there. And that could be potentially much more useful than what we call a point of care injection. So if you came to my office and said, I want my stem cells put in my knee, I could suck your fat, I could aspirate your bone marrow, I could spin that product, get an aliquot of tissue, but I would have no idea what the counts are, because I wouldn't have the technology to measure that. So I would be injecting an unknown quantity of your own cells into your body. And if you're over 40, your counts go down as you get older. So if you had a shoulder problem and a 20-year-old pitcher had a shoulder problem, I think the 20-year-old's going to get a much bigger bang for his buck with a stem cell injection than you are, just because you'll have less cells.
I'm afraid that line you mentioned earlier may have taken care of the rest of mine anyway, so.
Which line?
The wine.
Oh, the wine. All right. Well, thank you. I appreciate you letting me speak to y'all.